in the US at least, race, income, and education and health outcomes are all super strongly correlated. And it's so difficult to disentangle those.
Welcome to Self-Funded with Spencer, sponsored by Pareto Health, ClaimDoc, and PlanSight. Whether we're discussing innovative new healthcare strategies, exposing hidden revenue streams or misaligned incentives, or even just cheering on the next generation of this industry, we promise you that you're going to learn something. So thank you for joining us for another great conversation about the future of healthcare. All right, so cool. I'm here with Justen Nestico, and you're the head of Actuarial Solutions.
Actuarial Solutions.
Yes, of Verikai, man. Welcome to the podcast.
Thank you for having me.
I was telling you off camera, like that's always the only thing I have to remember, and I still screw it up like 50% of the time. So I'm glad I got it correct.
You did great.
Thanks for coming. I was gonna say coming down, but you came over from Tampa. Right?
Yeah. It's hot here too.
Hot here too. Yeah, it feels like home, man. Well, I'm really excited to get into this episode because honestly, this is something I've wanted to feature for a very long time, the Verikai solution. So if you will, very briefly summarize what we're going to cover, and then we're going to go into your backstory after that, if you're okay with that.
Sure.
Yeah, so what's Verikai?
So Verikai is a risk assessment platform that essentially combines medical, pharmaceutical information on individuals with insight into their overall behaviors, their socioeconomic status, their financial information, to get a better, more holistic insight into their risk over the next 12 or 24 months.
So using those tools or the access of that data to sort of aggregate a risk profile, if you will, for stop-loss carriers are most of the time going to be your partners, or who else would you partner with?
Those are the major buyers of Verikai. We do have a couple of producers, a couple of TPAs, and level-funded MGUs. But stop-loss carriers, MGUs, are the main, I'd say like 80% of the business.
What I like about this, and then we're going to go into your background, Justen, because I want to learn about you and your story of how you got into not only being an actuary, but being an actuary that they let talk publicly in a sales capacity, which is a weird combination as we were joking over coffee. But what I like about what you guys do is this really helps with one of the hardest things to do in our space, which is convert fully insured groups that are lacking data or have at least a less than ideal data set, and help them with that transition to self-funding, and help the stop-loss carrier or the MGU ultimately kind of make sense of it and feel comfortable with that risk. Because the more, I view it as the more employers that we can get converted to self-funded and then open up the world to the richness of data that you get being self-funded, the better off employers are going to be as a result of that. That's what we do at Pareto. Obviously, that's a big part of your mission. And so I'm very excited to dig into that. But first, let's go back in your story, man. Where'd you grow up? Where'd you go to school? What'd you study? All that good stuff.
Sure. So I grew up in Syracuse, New York. But I've lived all over the East Coast over the years. So I worked as an actuary for 7 years, a few years at Towers Watson before the Willis merger. Okay. And then at a company, or before that, at a company that had been part of PwC. And then I just, to your point, like we were talking about earlier, I felt like I needed a job that would allow me to interact with people more. Like, I really enjoyed being an actuary. I like the quantitative aspect of it, but I needed more like social interaction.
Which is kind of rare. I mean, maybe it's just a tongue-in-cheek joke and look at actuaries, but usually the personality traits would lend themselves well to digging into really deep data sets for long periods of time and not come up for air, but you felt at least your personality jived well with being able to tell the story publicly as well.
Yeah, and it's a stereotype for a reason. It's not 100%, but it's pretty close.
Yeah, and it's similar to underwriters too. But I've found that actually great underwriters actually make great salespeople if they're selling the thing that they underwrite for. And your role is no different, right? Because you so deeply understand the product that at some point you're just so convincing and compelling because of your credibility that it's easy to sell the product, or at least that I've found, at least an observational study of this space. So it's not surprising ultimately that you be good at out and selling. But you're telling me beforehand you were a roofer at one point too. Like, I got to hear this. Like, how did you go from being a roofer after college to getting into actuarial science?
Oh, it was very random. I went to college without any real plan of what I was going to do after. And I know a lot of people who become actuaries go in thinking like, okay, year 3, I'm going to take a couple exams and then get an internship. I did none of that. Okay. So I graduated and had no plan, no job. So
What did you study in undergrad, though?
I studied math.
Math. Okay, so you at least had a brain for it. What kind of math? Was this theoretical stuff, or what'd you get into?
It was more the applied stuff. So I actually double majored in math and physics.
Okay.
I was thinking like maybe I'll go for a PhD in physics, but I took a class my senior year that made me realize like I'm pretty smart. I'm not that smart. I shouldn't make a career out of this.
Fair enough. And then, so where did the roofing enter the fold? I just needed a job, or
Yeah,
what?
I graduated, and I was like, well, I don't want to keep living at home. I need a way to pay rent. So I spent some time doing roofing, doing demolition.
Okay.
And then it didn't take me long to realize I should probably get an office job.
Well, as I said, that's about as far a cry from actuarial science as I can possibly imagine. And I didn't spend like a long period of time doing it, but my dad every once in a while in the summers while I was in high school would say, yeah, come out to the job site and go lay some pavers for a couple of days. Like he would lay interlocking pavers and do like big commercial jobs with like pavestone and stuff like that. And I think it was after like day 2 of doing like a full day in the summer sun and, literally laying bricks for like 10 hours, I go, yeah, maybe this isn't the career path for me. Maybe I'll look into doing something else inside. But man, that was an eye-opening experience. It's hard, brutally hard labor, right?
Yes.
So you got away from that maybe as quickly as possible. So what was your first job outside of roofing then?
So for a while, I was doing construction work and then coming home after those long days and studying for the first actuarial exam.
Yeah. Was there a light bulb moment, though, that said, hey, I'm going to go back to this, or I'm going to look into this instead of the mathematics component, just go into actuarial science?
I literally Googled, what can I do with a math degree? And then actuary is always like the #1 job on those rankings, like the Wall Street Journal will publish. I was like, maybe this is a good fit.
Well, from that accidental start to where you're today, I mean, you told me you've passed all 7 exams and then additional ones that you do as well. I mean, how far can you do this for your whole life? Keep studying for exams or what?
I'd feel bad if you did want to do it your whole life, but I guess in theory you could. There's always more that you can study. And one of the nice things about the Society of Actuaries is it does provide a lot of avenues for continued education,
Sure.
continued professional growth.
Yeah, I mean, we have to do that in the life and health world as well, right? You think you have to do 30 hours of CE every 2 years, and it ranges from useful to not so useful, and just check a box. But I understand, like, we are supposed to be held to a very high standard as professionals, and so therefore you're supposed to be always learning. I just found I'm curious in general, and I think that curiosity has helped me well in my career because I almost feel compelled to keep learning. Otherwise, like, you get left behind by the people that are. And if you're in a role like you or me where we're obligated to kind of have a good level of understanding of the marketplace at large, then you're really doing a disservice to folks if you're not staying up to date. So when did you join Verikai?
Right at the start of 2021.
Okay.
Yes.
And how did you become aware? Was it in startup mode still at that point, or when was it lifted off the ground?
It was.
Okay.
So Verikai came to market in 2018. It had been going for a little while, but I'd say 2021 was really when it started hitting its stride.
What was it about? Just the development had kind of caught up with the vision, or tell me about that?
I think the first couple of years were the co-founders kind of hunting around for the right use case for the type of data we had. I think sometime in 2020, they kind of stumbled on that conversion business use case.
Yeah.
There was a lot of demand there for how do you quote groups or get insight into groups where you have no claims data or very limited data.
Yeah, so pre-underwriting tools, and I know there's some other versions out there, I featured one on the show, but pre the development of AI and its application for underwriting, walk me through what was a typical group doing that was maybe fully insured with no data or limited data. How was that group getting through the system to be underwritten properly and becoming self-funded? Like, what did it look like prehistoric days?
As far as I know, they just weren't getting quotes.
Yeah, okay.
Like you go to your Blues broker and you're going to get a fully insured quote. And if you try deviating from that without any other information, a lot of stop-loss carriers or MGUs would not quote that business.
Yeah, I mean, at Sun, I worked at Sun Life, and I think under 200 lives at that time, I don't know if the rules have changed, but under 200 lives of fully insured to self-funded transition, they wouldn't even really look at because there were such super low conversion rates, not just because of the lack of data, but usually also just fully insured to self-funded transitions are hard for a number of reasons. You got to convince them to switch their funding arrangement. And so we're rare exceptions to that rule. But they took that stance, and some carriers are way even higher up market than that. And so it left this, subset of the population that Pareto's trying to address and has addressed, but it left this subset of the population that wanted to be self-funded, but it was just too difficult to go through. Or you do level funding as a stepping stone, or some other product that was out there that you could use questionnaires in order to get through the final underwriting. But none of it was great, right? None of it was like super powerful and scalable. And so enter this new emerging space that you guys are in. And what do you even call your category? Verikai, does Verikai AI in underwriting, or is there a category that you and your kind of peers exist in?
At this point, I'd say the product is AI risk prediction or risk scoring. The way I see Verikai evolving over time, and we can talk more about this later, is in much more broadly in cost control, care management, more on getting ahead of things.
Kind of the predictive but management or mitigation, if you will, almost
exactly.
To a degree. Okay.
Instead of quoting or assessing the risk right up front at the time of quoting, kind of watching it over time and getting like an ongoing monitor of the underlying population so you can kind of control the costs across the entire book.
Pareto Health is the manager of the largest employee benefits group captive in the United States. And it's also now the main sponsor of the Self-Funded with Spencer podcast. I chose to partner with Pareto Health for three main reasons. Number one, their dedication to improving the world of health benefits. Number two, their mission to reduce volatility and to make self-funding simple for mid-sized employers. And number three, the strength and scale of their program. With over 2,300 member groups and more than $1 billion of stop-loss premium under management, Pareto Health is the most robust solution of its kind in the country, period. Stay tuned for more information because I'm sure I'll be featuring them on an episode of the podcast very soon. Visit Pareto Health at paretohealth.com or follow them on LinkedIn to stay up to date on the latest news and developments.
Okay, yeah, I would love to get into future state, but why don't we do current state, right? Because
Sure.
I think people have probably that listen to the show might have heard of Verikai in passing, but I really want to understand how it works, right? So if you could help me lift under the hood as much as you're able to share. But like a common example, fully insured transition, right? Don't have any, let's assume the group doesn't have any data. What does Verikai do at that point? How do you help?
So it's not necessarily true that they don't have data.
Okay.
It's just that the fully insured carrier isn't providing it to you.
What? Yeah. Okay. Yeah. Obviously, that is the case. Yeah. So I'm glad you clarified that.
So part of what Verikai is doing is reaching out to these EHR systems or medical billing software systems and pulling in ICD-10 codes, J codes, prescription drug codes, all of that information. And that's not unique either. Like Milliman will do that, Gradient will do that. What is unique about Verikai is that we're also looking at thousands of behaviors on each individual in that census,
Okay.
as well as neighborhood characteristics, characteristics of the home. And what we're trying to do is use machine learning to tie those behaviors or characteristics to the claims.
Okay.
And understand what's actually driving the risk. What that allows us to do is get a better insight into what future risk is going to look like over the next 12 months beyond just looking at these are the conditions we already know or is in this population.
Okay. So like if that reporting does exist and either the carrier is not releasing it, or like in Texas, we get access, I think, twice in a 12-month period to a limited reporting data set. So it's better than nothing, but it's still pretty opaque to really understand what's going on. You use this extra data to round out your understanding of the group. Is this what they call the social determinants of health, that category? Or I've heard of that term. Is that what you're describing, those behaviors that you're able
Yes.
to tap? So define that. So social determinants of health, what does that truly mean?
The way I would define it, or the way I think of it, is it's all of the things that influence health that aren't genetics.
Okay.
Right? So it includes your personal behaviors, but it also includes the characteristics of your neighborhood, like pollution levels, like how far away from hospitals are you. It includes things like the influence of your friends and your family on your personal behaviors. So all of that eventually manifests itself in your health status and therefore claims.
Well, yeah, because you're trying to get a profile of the whole person, right? But then the whole community beyond that, right? And what are common behaviors, whether they're purchasing behaviors, lifestyle behaviors. I'm sure you're factoring in income levels, education levels, all of those things into that to really get a really deep level of understanding of that risk profile. But how do you source that type of information? Where's that coming from?
The behavioral information comes from a lot of different data aggregators. And I'd say that the most important of that behavioral data is the purchasing information.
Really? Okay.
Yes.
Why so?
It's a bigger indicator of intent, or how you actually live your life, right? Like if you take me for an example, I think I follow Nike running on Instagram, but I'm not a runner. And you would know that when you see that I don't buy running shoes, right? I don't sign up for marathons, right? But for somebody who is a serious runner, you would see that indicator in their purchasing data.
Okay, and so that purchasing data, and I think this is where I was a little surprised, right? Like the purchasing data is coming from credit card transactions and things like that, right? And so all of us, let me tell you, correct me if I'm wrong, but all of us have sort of not knowingly or maybe knowingly agreed to allow that data to be released by our credit card companies to other aggregators of data, right? So like you guys are just using data that's out there that exists, but I mean, they can see if I'm buying cigarettes too, they can see if I'm buying, protein or something to that effect, right? And so that picture will shape my risk profile as an individual, and then how that shapes the whole profile, right? Is that understanding correct? Or
it is, with one caveat.
Caveat
that we don't know that Spencer Smith.
You don't know Spencer Smith is doing this thing.
Exactly.
Yeah. Okay.
Everything, part of how we do what we're able to do in a HIPAA compliant and legally compliant, more broadly way, is totally de-identify that. So there's no names, no dates of birth, no social security numbers, none of that stored in our data. It's all replaced by a token, a really long, nonsensical token that is unique to you, Spencer
Is
Smith.
this on the blockchain then when you say tokens, or am I totally off base?
Not on
I'm
the
like
blockchain.
into crypto and stuff like that. Okay. But I understand the intention, right? HIPAA is a big part of what we do, protecting PHI. You don't want, if there was a hack ever, right, that ultimately you don't want all this information to be released because then there's exposure. This is sensitive information, right? What are my spending habits and things like that? And so you guys are clearly, obviously, protecting that to as far a degree as possible. But we can glean good and bad information, if you will, or optimal or suboptimal health outcomes as a result of that. So why don't we focus on the suboptimal things that we uncover first, and then we'll go to the more optimal health ones. But like, what are some red flags, or what are some behaviors that are very obviously perhaps correlated with bad health outcomes?
It's an important thing to know is it's never one thing.
Okay.
So alcohol consumption is, I think, my favorite example, because there's a situation where it's associated with really negative health outcomes and really negative or high claiming activity. And that's if, say, you're in a neighborhood trending toward bankruptcy, you personally are buying a lot of alcohol and not.
So you are looking at location too. Location's obviously one of those very specific variables. So what would you glean from location other than what we just described? What else? You said pollution, maybe there's health behaviors that are common, there's wealth levels. Like, what else are we looking for there?
We'll look at things related to, like, how far from the nearest emergency room are you, the nearest hospital, the quality of that hospital. Stuff like that has a lot of impact on claiming activity and cost. And then, like you said, pollution, like stuff like that manifests itself through the frequency of ER visits for children with asthma.
Okay.
Stuff like that.
Wow, that'd be interesting. I was actually interviewed a gentleman named Brian Marcotte the other day, and Brian was the president and CEO of Business Group on Health, and he also ran Honeywell's benefits for a number of years. And we were talking about DPC, and there's a reason I'm bringing this story up, but we were talking about DPC, and there was a story where somebody was going to the ER really frequently, and rather than just continue to allow them to treat over and over again at the ER, the primary care model that they had allowed the employer to investigate downstream what's happening, and they actually sent somebody to their home to look at what the conditions in the home were like. And apparently, obviously not great conditions. The air quality was poor. They actually ripped up the carpet in that guy's house and then replaced his carpet and helped with some of the other filtration systems, with the idea being that home-based environment was causing the asthma, which was causing him to go to the ER because that was his only option. And rather than look at how do we steer him to an urgent care, they went all the way downstream, and it's like, how do we fix the actual environment of the home itself so the asthma stops flaring up quite as often, right?
Yeah.
So just kind of anecdotal story, but related to the conditions of, like, what does the environment do to shape our physical outcomes as well. Air pollution's got to be one of those obvious ways that could impact it.
100%. And the most surprising thing about that story was that the employer like took that extra step.
Well, the idea was, and being, again, the flexibility, I mean, he was talking about, I think, virtual primary care with like a sort of multi-specialty focus, like really trying to unpack and break apart primary care and then put it all back together with what they would want it to be in the future. And so that was an example of a situation where they had enough foresight to actually address the root part of the problem. And since it wasn't a traditional fee-for-service model, no fee-for-service primary care physician is going to send a nurse out to your home to see what your home is like and then replace your carpet for free, right? They understood that intervening in the trend of overutilization of ER by fixing the root problem stopped the overutilization of ER, and they had enough flexibility to do that with the plan design.
Yeah.
Pretty cool. Yeah, pretty cool stuff.
I've heard similar stories, more on the Medicaid and Medicare side, where the plans will help pay for like pest control. Same reason, right? Just the air quality causes problems with asthma that just creates a lot more complications and cost long term.
Well, and I think what this maybe is opening us up to, and then I want to get on the positive side as well, of like things that you can show that might correlate to better health. But doesn't this open this up to the conversation about sort of inequalities in healthcare outcomes, right? And whether or not that's across financial lines, across racial lines. We were talking about food deserts over coffee this morning. But I'd love to see, like, how does this stuff perhaps uncover some of that systemic, the systemic issues inside of our system?
It's what our models are uncovering are in line with I think what's generally known about inequalities in healthcare. And by that I mean, in the US at least, race, income, and education and health outcomes are all super strongly correlated. And it's so difficult to disentangle those.
Yeah.
So in our data, we see what you would expect to see, like minority women, or essentially African American and Latino women. They see much higher rates of premature births, much higher maternal mortality, stuff like that. We can't really say it's because of one thing or the other necessarily, because everything's coupled so tightly in terms of the correlations.
Sure.
So at this point, all we can do is really try to identify like who's at higher risk, and then think about what interventions can.
Well, that's, I'm not expecting you guys to solve whether there are systemic inequalities or maybe they exist for other reasons. I'm not suggesting you guys can solve for that, but it's interesting that your data actually sort of proved what was maybe already known. But that further confirmation then begs the question, right? So like, what do we do about it, right? And that's the $1 trillion question, is like, how do we fix that? And is some of it behavioral within certain populations? Is it some of it genetic? Is it some of it because of systemic pressures or anything? Like, I don't know the answer to that. I'm almost just speaking out loud and kind of thinking about it. But like, that would start to beg the question, is like, the now what? And I'm sure you guys every day are starting thinking about, oh, okay, we know this now. Well, now what, right? What do we do about it to fix some of those things? Do you ever get involved in sort of the tinkering and the problem solving as you uncover more things like this, to go, do we develop a product around that? Do we develop a service around that? Do we call other thought leaders? Like what does an action plan look like after you maybe uncover something to that effect?
We are in the early phases of that. So part of my goal for Verikai is for us to move much more in that direction toward like care management. I think the value we can provide to health plans, to captives and stop loss carriers is much greater on that side. The ability to get ahead of stuff. So instead of controlling costs by, changing what you pay when somebody's in the hospital, actually control costs by keeping them out of the hospital, being more proactive and intervening earlier. The example, the most interesting thing, and you and I were talking about this a little bit earlier, is the new class of GLP drugs.
Okay. Yeah.
Right. If you think about inequalities in America, like race, income, obesity, all really strongly correlated, and the complications that come from obesity are potentially huge, right? In terms of diabetes and heart disease, stroke, stuff like that. So it is interesting to me how this whole GLP situation evolves, and how the cost effectiveness turns out, the stickiness of the weight loss.
Yeah.
I could see a scenario where essentially minority candidates, if you want to close that racial gap and reduce costs, they become much stronger candidates for these drugs, as opposed to right now where it's actually harder for them to get access to them.
Well, and I think you were saying even coffee, it's hard for a lot of people to get them nowadays.
Yeah.
I think even a very, very small percentage of our employers at Pareto right now are covering them for weight loss alone. Of course, they've been indicated for diabetes for a long time, but this new application of just purely for weight loss purposes only is still relatively in its infancy. But we are projecting, at least, and I think it's going to be true, is that it's going to be, in terms of a category of drug, it's going to be the most expensive, most likely in 2024, maybe even 25 as well. So we're thinking about how to get out in front of it too. So what do you think will be done? What gives you sort of a bullish outlook that it actually will improve claims pick over time? Just because the risks outweigh, or no, it's the advantages outweigh the risks, if you will, or tell me what makes you think that?
I don't know that it will.
Okay, you don't know that will. Okay.
Yes, but I think it's possible that it will. I think what people need, what the industry I think has to figure out is how to make that weight loss stick.
Yeah.
Because if it's $1,000 a month every month off to infinity, then it probably doesn't make sense. But it's also, from the research I'm seeing coming out now, these drugs are the closest thing to like a miracle drug that we've seen in a while, at least in terms of obesity, right?
It's a powerful catalyst. Like, I think if anything else, for what it's purported to do, seems like it definitely does do that, right? And does it in a scalable and repeatable way. I'm with you, though. It's like, how do you get that person that maybe has gained weight over a very long period of time, and let's say they need to lose 100 pounds, they're pre-diabetic, now loses 15% of their body weight, that's great. But if they haven't changed anything they're doing on a daily basis, the stuff that led them to gain that excessive weight, if they haven't changed anything about their behavior, eating habits, exercise habits, et cetera, then the drug is basically the Band-Aid that's keeping that weight off. But as soon as that drug is removed from the equation, then what, right? I'm really scared about the then what after that.
Yeah, that's I think the billion-dollar question, right? I don't know that anybody has that figured out yet.
Yeah.
And everybody's taking a wait-and-see approach. If somebody does figure that out, I think the ROI on this class of drugs can be phenomenal, because it's not just obesity, it's not just diabetes, it's heart disease, stroke, fatty liver. I've seen studies now that it reduces drinking for people who have a problem with alcoholism, reduces smoking, reduces craving for opioids, reduces sports gambling, right? Whatever it is that makes people do anything compulsively.
Yeah, did you watch that episode where the guy was on the diary of a CEO, and the gentleman was talking about Ozempic? He's a reporter. He's a British reporter, I believe, and he had his own personal life lesson with it, right? And he was listing off side effects and things like that. It was a really interesting long-form conversation. But one of the things that he said to what you're saying is that it's very probable that I think it's impacting either the processing or the release of dopamine in our brain. So all those things where we get a high from smoking to everything from gambling to sexual intercourse, you name it, that it's actually sort of downplaying or reducing the impact of that. And therefore, now all of a sudden, the things that maybe brought short-term joy or stimulus too, I'm no longer interested in. So like, what's the impact of the malaise that might come over a human being now that they didn't expect? Like, all these things are open-ended questions because it's too new right now to actually know. I might be worried about, you remember a fen back in the day? I don't know if you remember this.
I do.
Like, similar sort of burst onto the scene, miracle weight loss drug, and the next thing you know, there's all sorts of like dire health consequences and lawsuits. Now, obviously, that's pulled from the market and nobody's using that anymore. I hope we don't see something like that too, where a lot of people just destroy their health because they went into it without a lot of thought about the side effects. Just my personal opinion, not the opinions reflected of anybody else, my personal opinion. Yeah.
I'd agree with that. And it's always, like any medication, cost-benefit analysis. So you probably, because we don't know about those long-term side effects, you probably, if you're already a healthy weight and you just want to cut down for the beach or whatever, probably not a great idea. But, I mean, there are real consequences to being morbidly obese. So
100%, right? Like, so I think that's maybe the only, if I had a point to all of my sentiment, is that the people that need it should get access to it, absolutely. But we should be intentional about how we select or sort of guide who should choose it and who shouldn't. And if we do get those people that the benefits outweigh the risk, then we should also arm them with lifestyle and behavioral modification tools so that they do keep the weight off forever. Maybe that's the best way to put it at this point. Okay.
PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. Well, what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
Well, so let's flip to the health outcome side, right? Because we talked about some of or is there anything else, let's say, on the bad end of the spectrum of risk profile and some of the things that you guys are uncovering, like the red flags? You want to stay there for a second before we move on?
The only thing I'd say, one question we always get is how much emphasis do the models put on the behaviors versus the medical?
Yeah, okay.
And my answer is it really, really depends, right? If you're talking about a hemophiliac, that's driving the risk. It almost doesn't matter anything else they're doing in their personal life.
Yeah. Yep.
Whereas if you have some healthy 20-year-old Olympic swimmer, right? In that case, the behavior carries a lot more weight because there's not those high-cost conditions that are driving the risk. When we are scoring a group overall, it's really kind of doing that type of calculation for every individual in the census and then just kind of summing it up into some aggregate.
And what does a risk scoring look like? Because you said the other models out there do a risk score of some sort as well. Like, what does your risk scoring of a group look like?
Essentially, and I think all of the competing products do something similar. We score with a 1.0 baseline, where a 1.0 corresponds to the average person across the country.
Okay.
Average across all ages, both genders. Yeah.
Okay, and so that if one's a baseline, what does the range then look like from there?
The lowest in theory is 0.
Oh, there is a 0.
Yeah, but I mean,
that means you don't have any employees at all and your business is out of business? Like there's no risk?
It means we expect $0 in claims for the year, so they never actually occurs.
Yeah, fair enough.
On the high side, it can go to infinity. Right?
Okay.
If you have a 100-person group, they could be 100 people taking hemogenics for hemophilia.
Yeah.
Right. But we never see that either.
Well, yeah, like you said, everything's on a bell curve. I think you do a distribution on a bell curve. We develop what's called an indication at Pareto, which is our initial sentiment of what this group's risk profile would look like, sort of that spectrum of possible outcomes, from like a $0 claim environment, which is statistically impossible, to like hitting every possible max, you overuse your capital, everything blows up. Like that's almost as close to statistically 0 as well. Somewhere on that bell curve, the majority of groups are going to land. So it sounds like you guys are using a similar continuum.
Exactly.
Yeah. Okay.
And in practice, I think for most of our customers, it's more helpful to just know roughly, like this is in the worst 20% of groups you're likely to see. So pay extra attention. You may want to write it at some load on the premiums, or you may just want to decline to quote altogether. We kind of leave that up to them.
Well, and that's what I'm glad you actually clarified that, because I was thinking at the front end, and I think I would share your opinion that every group can be written at the right price point, right? The number of lasers written, the attachment point, all the premium. If it's underwritten properly, it still could be underwritten and be self-funded. That doesn't preclude that group from going self-funded at all. The question will be, of course, with the consultant and the employer, is that a palatable number for them to actually decide to purchase or not? But if the stop-loss carrier looks at it in totality, I think every one of them could place enough lasers on a case to write just about anything, right? Yeah.
Sure. And there are a lot of levers they can pull. The nice thing about tools like Verikai and some of the other ones that are out there is it gives them the insight so they can decide which levers to pull. Before, when they couldn't get the claims data, it was really hard to do that. Like you kind of, unless you get like really up-to-date health questionnaires, it's tough to know who to laser.
Right.
You don't know what you can do in terms of sourcing drugs differently, anything like that.
Well, and if they're, lasering is obviously difficult when you don't know who the claims are coming from. And so therefore, sometimes we'll use an ag spec as a sort of defense mechanism. I say we, our stop loss carrier partners will do that. Do you guys help with the identification of where maybe some of the lasered claims are coming from, whereas it may not be sourceable in the actual claims data itself or be available to get?
We do not,
Okay.
even though internally we may know or have a strong idea of which person
Yeah.
has which condition. For HIPAA reasons, we do not disclose that.
Yeah, and so therefore they can't be lasered, right, at that point, right, which makes it a little more difficult. So there's no bulletproof or silver bullet for that particular situation, right?
Exactly.
Because it's non-compliant with HIPAA because then you're singling out an individual that otherwise wouldn't be known, I guess, or
Exactly.
Okay.
I think, and I'm not a HIPAA lawyer.
yeah, me neither.
I think if they can identify the individual, then that's fine, and they can take the action. But we just can't be the ones to tell
Yeah,
them.
but hey, by the way, you're
This
like
person-
sliding a name across the desk.
Exactly.
Fair enough. Yeah. Okay. Well, then I think obviously, if health care risk scoring is a continuum, like we said, from good to bad or great to terrible, right? Whatever that the endpoints are, then there are things that people are doing and even businesses are doing that suggest better outcomes overall or a better risk score overall. And I think over coffee, I asked you if maybe we could come up with a list because you said there's 4 or 5 variables that very strongly correlate with good outcomes, not necessarily on their own, but together. So what are those ones that are the big good identifiers for maybe a good risk profile of a group?
Yeah, and I'm glad you did say correlate because the stuff, even the first one I'll mention, low intensity exercise.
Yeah.
It's not clear to what extent it causes good health outcomes as opposed to just being correlated with it. So when I say low intensity exercise, I mean walking, jogging, yoga, Pilates, even gardening.
Yeah, okay.
I don't mean
CrossFit
crazy, no CrossFit, no crazy weightlifting or ultra marathons. But it's unclear without doing further analysis whether those activities make you healthy and then claim less, or if you're just able to do those things because you are healthier and you're not bedridden.
Well, it's the chicken or the egg question.
Exactly.
Almost. Yeah.
In reality, it probably goes both ways.
It does go both ways for sure, right? If I feel good, I'm more likely to go out and go on a walk, right? Or maybe, I'll do some gardening today because my back doesn't hurt or something to that effect. That makes sense. But the specificity around low intensity exercise, where's the breaking point? Is there something in your model that then this is high intensity and then might have a negative correlation with health, right? Or where's that switch happen?
We don't have that granular of data. It's not like we're at this point collecting Apple Watch data to monitor heart rates.
No Whoop data or anything
Yeah,
like that?
nothing like that. But it's just a collection of the types of activities that are in this bucket that correspond to better outcomes versus the ones that aren't, like CrossFit.
And ultra marathon running or skydiving, perhaps.
Yes.
All right. So back on the subject here. So we've got low intensity exercises, number 1. What's number 2 then?
Number 2, I think, is the most interesting finding that I've seen, which is your degree of religious activity.
Okay.
Is really strongly correlated with better outcomes, all else equal. I don't know why that is. I could make an argument that something about being religious or being faithful it lowers your stress response and cortisol, which has downstream impacts. I could also see an argument being made that just the social connections that come from going to church weekly or twice a week is really beneficial.
Yeah, I would speculate all those things are probably true to some degree. I mean, I even think the sense of a higher purpose, right? Or so not just, hey, I'm just living my life and subsisting like I'm here for a reason or my life has meaning. All those things have to, not only from a mental standpoint, improve health, but I think then if you're mentally feeling good, then you're physically feeling good. And it's that whole person sort of vantage point. But I have no doubt, and I've heard that actually, before you brought it up, I've heard that to be true, right, in some other studies as well. It doesn't matter the form necessarily of religiousness as well. It's just, does a religiousness exist to a degree in that person?
Yes.
That's super cool. So your data confirmed that point.
Yes,
Okay.
and it's the strength of the correlation was really surprising too. So it matters across all spec deductibles, even like $250,000 spec levels, you would think at that level, you're really just talking about the medical conditions, the behaviors kind of aren't that important.
Yeah.
No, it's still, religiosity is still there as a factor.
And does the correlation share a similar scoring from like 0 to 1, or what? The strength of the correlation? How do you measure that?
Yes.
Am I getting too geeky? I don't know if I'm getting too geeky for this podcast. But.
No, this is actually a really interesting, geeky part of the conversation. So we've spent a lot of time in the last year, because of criticisms we've had that our models are a black box, doing a lot of work on explainability.
Okay, yeah.
So taking the models as they are and trying to extrapolate the feature importance across all of these thousands and thousands of variables. And then from there, just kind of seeing what has the biggest magnitude impact and trying to bucket them.
That's super cool, though. I'm glad we're having this conversation. I want to keep us on track for the list. And Nathaniel, if you'll make it a note, I want to probably put this into a clip because I think it's cool. So we've got low intensity exercise, religiousness is number 2. What's number 3 on this list?
Number 3 is, I think, similar to the way that you need to exercise your body. The number 3 is having hobbies that are mentally engaging.
Okay.
So puzzles, games, collecting things, reading, stuff like that.
So you think just keeping your brain stimulated and entertained, and presumption as a hobby is something you voluntarily choose to do, right? So it brings some joy.
I think so, but again, that's one that I could see, like maybe there's a social component to that.
True.
Like you engage with people, and that has health impacts and well-being.
Yeah, I mean, you could obviously like overlay your finding on like Maslow's hierarchy of needs. You know, social component is right there in the middle.
Yeah.
That'd be actually pretty interesting to layer those on and see, does that follow the same hierarchy of importance? Religiousness, of course, is in the social component too. But that's interesting. I mean, I think a hobby, I'm trying to draw a through line. Each one of these suggests to me that you have some volition over your choice of what you do with your time. And if you have choice to do with your time, that means you have discretion. That means you have probably a higher quality of life. You're not hunkered down 12, 15 hours a day doing manual labor, and it's physically taxing on your body, and you don't have time for anything else, right? So I'm assuming there's a wealth component maybe in this list as well. Am I getting ahead of myself there?
Yeah.
Okay.
And that actually is a good segue into the fourth main thing, which is the kind of car you drive.
Okay.
It turns out if you drive a Mercedes or a Lexus, you tend to claim quite a bit less. But again, it's not that the car itself makes you healthier or anything
proxies,
like that.
right?
Exactly.
Yeah.
In America, wealth is so correlated with health, with education, with all of those things that turns out the best proxy, or one of the best proxies, is the type of car.
Well, so if you will, after this at some point, no pressure, look up Roush Mustangs. Do Roush Mustangs correlate strongly or poorly with health outcomes? I need to know where I stand, because it's not your traditional luxury car, but they're fun to drive.
Will it make you feel better if I just tell you?
Yes, please.
Good outcomes.
I'm good. Oh, yes. Let's tell my wife that. Okay, so low intensity exercise, religiousness, hobbies, kind of car you drive, and I think there was a number 5 right on this list.
Number 5 is essentially big umbrella, your comfort level with technology. Like,
okay.
Do you subscribe to streaming services? Do you purchase online from, say, an Amazon? But it's important to note that this is all independent of age. So across all ages, if you're doing these things, on average, your health outcomes and your claims tend to be a lot better. I could make an argument that...
Yeah, this one was a little bit confounding for me. I didn't quite understand. I couldn't explain this one exactly, right? So what's your explanation?
My guess is it's something probably to do, it's probably correlated with education, which again is itself correlated to wealth and health outcomes.
Yeah.
So I think people who were earlier adopting technology, who tend to be a little bit more on the cutting edge in terms of that stuff, tend to be more educated, tend to live in wealthier urban settings as opposed to poorer. But again, that's just a hypothesis.
Yeah, that one was, I could see that, right? Maybe more streaming services, and I assume it probably includes, all sorts of different packages that you have the means or at least the discretionary income to purchase, right? Again, further suggests that you have a little bit more control over your time, and therefore maybe that autonomy suggests that you're just in a better financial position. I think all of that would make sense together. That was just the one on its own that I didn't quite understand, because some streaming services are $4.99 a month, and so you could literally binge watch, Netflix all day or something to that effect and not necessarily be a healthy individual. So that was the only one that was confusing, but I think in totality it makes sense when you put them all together.
Yeah.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
Long and short, though, wealth seems to be one of the biggest differentiators, right?
It's the U.S.
Yeah.
It's so correlated with everything. And it's so difficult to disentangle wealth itself or income from race, from education, from literally where you live.
Yeah.
Right. It's just so strongly related.
Well, so then that begs the question. We know this information now, and obviously you said your model has kind of confirmed some of the things that were already known. But I'm a big guy that's like, okay, now what? Then what do we do with that? How do we fix whether it's a systemic issue, whether it's an issue of some inequality that exists, or it's simply a behavior issue? Is there anything that you think in your mind, you think about how do we address some of these things? I mean, I think that's what you're talking about, the future looking, what Verikai might be getting into. But now that we know this stuff, we can start to try to fix some of it.
Yeah. I think the example you gave earlier about the replacing the carpet is a perfect example, right? Like being able to identify individuals who are in riskier situations or in situations that make them more likely to claim higher than they would otherwise. Identifying individuals like that and intervening early before they're going to the ER it's an opportunity, yes, for employers and stop-loss carriers to reduce claims, but it has the ability to improve health outcomes, improve mortality for individuals, close the racial gap. There's no limit to what people can do. The one example that I think is most interesting to me, and I see this as something Verikai pursues in the very short term, is the premature births.
Yes.
So that's something we know that there is a huge socioeconomic component to. Essentially, Black and Hispanic women have one set of outcomes, and everybody else has a different set that's like 3 times better.
Okay.
But that's also a case, especially because of the prolonged NICU stays, where it's very expensive. And it's one of those conditions, it's always top 2 or top 3 in the Sun Life report.
Yeah.
Right, so that's a situation where there's a real opportunity to improve outcomes for the individuals, reduce costs for the carriers and the employers, and actually, socially improve the racial gap, right? Bring Black and Hispanic maternal mortality or infant mortality down to the levels that we see elsewhere.
Well, sure, there's some of those things, though, would lead to better maternity management, access to more frequent trips to maybe the OBGYN, I'm sure nutritional components, all of those things. And so if they are absent today, I mean, we're in this really weird space in healthcare where it's so fragmented, it's so complex. There are so many problems that build on one another that you can't just go, well, if we solve that, there'd be a cascading effect and healthcare would be solved, right? So that's one of a microcosm example of this macro problem that we're all dealing with. And I'm just, sometimes you wake up and you go, I'm going to do something good today. And then some days you wake up and bang your head against the wall. This is never going to get fixed, right? And I waffle in between all the time. But just hearing something like that, just a singular example, it's like even that seems really, really complex to solve for. And then the question begs, who solves for it? Is it the government? Is it the private sector? Is it the individual? Is it an employer? I mean, I don't really have an answer, but it's a reason why those things haven't been solved for today is because they're too complex, if you will, to just say this is the solution for it.
I think a big part of it, probably the biggest step, is just making sure the financial incentives are in the right place.
How so?
So right now, what's happening in Medicare, and I'll switch back to the commercial market in a second, but CMS is putting a really big emphasis on Medicare Advantage toward addressing social determinants of health, improving health equity, stuff like that. I think the other part of that is they are shifting the reimbursement models to support that.
Okay.
So getting the financial incentives for all of the Medicare players in line. I think the infrastructure for that is slowly migrating over to the commercial space. Where I see it happening most right now are, and I know you work for Pareto, but these captives that have a high degree of clinical integration. Because of all the players in the group commercial space, it seems like the financial incentives are most in line with this type of proactive care management.
Yeah, I think financial incentives probably dictate the majority of the behavior in the healthcare system. I mean, if you want to complain about fee-for-service, then you would look at just what are the financial incentives of that. If you want to get certain behaviors inside of your plan with your members, well, what are the financial incentives that they're responding to today? And if you're getting outcomes that you don't want, then what are your incentives doing to drive that behavior? And probably how easy could you fix that? I think when I look at deductibles being such an impediment to accessing care, if you can insert things like, I'll use KissCard as a great example in our ecosystem. They're now Valence, but KissCard is these direct contracts for things like imaging and minor outpatient procedures. And if an individual that has KissCard available to them goes and uses that service and goes to a location that is directly contracted with, not only is it cheaper for the employer, but the individual has their out-of-pocket cost waived altogether. So they're properly incentivized to use that tool. You just have to scale that thing up across the health plan and not just solely for individual components of it. Do you ever see any of these? Do you look at $0 deductible plans? There's a bunch of individuals out there that are building these models where basically the plans are waiving out-of-pocket costs altogether if they do certain things. Like, do you ever look at those, or have you applied that variable inside of your model yet?
We have looked at it. The problem is we don't have enough claims data on those plans
Still
to have.
too niche, yeah.
Yeah, any analysis we do isn't fully credible yet.
Yeah, that's too bad, because I am a believer that if that impediment is removed, it's not going to lead to higher claims outcomes. It's not like I would run to the doctor tomorrow and get some crazy surgery because I didn't have a deductible. But what I think is going to happen, if I'm correct, is that what will happen is just incrementally people will go to the doctor for things that are less invasive or less severe and check things preventatively more often as well, which should prevent the worsening conditions over time. And I think that's what we're seeing with high deductible health plans is people delay care and pill split and aren't adherent to medication because their impediment is the cost that comes out of their pocket. And so something has to get really severe before they go to the doctor, and sometimes it's too late as a result.
And if they go to the doctor, it's usually an ER. Right. They're using the ER as their primary care.
Yeah, man. You and I, if we just whiteboarded in a room, I feel like we could whiteboard some of these solutions together, man. But I'll get us back on track with Verikai.
Let's just solve a $4 trillion.
Just spend a couple hours with me in a whiteboard. I promise we'll get it. But so you mentioned I want to inch into the future of Verikai, and then if you'll give me your sort of future looking of healthcare in general. But so you really believe that Verikai has a role to play in more interventional and ongoing relationship to the plan. So was that care management, or what do you call that, or what do you think that will be?
Yeah, I don't know. The care management's probably the best term for it, but I view it more AI-enabled intervention healthcare, right? And to me, that is the big difference between Verikai and some of the companies we compete against currently. Right now, we're in the space where we're risk scoring for stop-loss carriers or MGUs, a lot of whom are looking for that conversion business. But long-term, the ability for us to kind of bend the curve and help control the risk and monitor the risk on an ongoing basis using all of this other data that we're pulling in that nobody else has. That is, to me, the differentiator and the potential financial benefit to both employers and the stop-loss carriers are a lot greater in that scenario.
Yeah, I mean, I think it's something like a trigger report that obviously give you some indication of an upcoming event, right, that could be intervened from the TPA. Now, what if you had some triggers that you were able to flag inside of your data set with the credit card transactions as an example, right? Like, I don't know what that may look like, but there might be something that is purchased that go, whoa, hold on, what's going on here? Does this individual have XYZ? Are they trending towards maybe even, I don't know, suicidal ideations. I don't really know. I'm just trying to think of things off the top of my head. But I could see where your data set enriching the existing claims data set in a really real-time fashion could absolutely help intervene in situations.
Yes.
Yeah.
One example, and you and I discussed this earlier, is identifying individuals who are at high risk of opioid addiction.
Yes.
Right?
Yes.
It's not necessarily just seeing that they are prescribed certain classes of medications, but also looking at the whole individual and all the other things that put them at risk of any type of addiction. The combination of those, in theory, would create some sort of light bulb that goes off and allows some sort of intervention.
Do you envision Verikai being the intervening party, or that data being passed on to an employer, a consultant, a TPA, like, hey, we see this, but it's not maybe our role to step in, or would you actually take a more proactive role? Again, this is hypothetical, right?
Hypothetical.
I understand that. Yeah.
If it was my choice, I would want to be the one to do it.
Okay.
I think because we have the data, we're closer to it, and we understand.
You probably understand it better than anybody else would, right?
Yes.
Yeah, why it's a concern.
I think it would be challenging for me to make that case internally.
Yeah.
I think we just want to be a data analytics company. And
Well, I guess you have the risk of like a person picking up the phone and be like, who are you and how do you know this, like, about me? You know, that obviously would, you know, maybe be concerning. But whatever form it takes, I think I'm going to agree with you, at least your hypothesis, that that data would be useful, because all of this is useless unless you can get in front of a bad outcome. And so I applaud you for even thinking down that path. I'm hopeful that it comes to fruition. Of course, I know the world of kind of building things, and you know, you have lots of ideas and not all of them come true, and that's totally understandable, but that's part of the build, and that's the fun of it. So why don't we zoom out, and then we'll finish the podcast. But Justen, kind of big picture, like healthcare. I usually ask people to consider open-ended where healthcare is going, this sector that's $4.5 trillion or whatever. Where do you think it's going the next couple of years? What are you bracing for to happen?
I think kind of like what I was saying before, the shift at CMS and the changes it's instituting on the Medicare space is going to change everything. Right, it's not going to be confined just to the Medicare space. So the combination of the focus on social determinants of health and health equity on how plans are rated, as well as the push to really get all the traditional Medicare members into some sort of accountable care organization.
Okay.
The goal with those is to get the financial incentives aligned. So capitated care, actually treating the individual instead of just trying to upcode. I think that eventually will migrate to the commercial space. Mm-hmm. So we'll start seeing, hopefully, a lot of people have been wrong on this before, but seeing a greater alignment of incentives. So instead of, I don't know, just all the tricks that carriers can do to try to control costs or whatever they do, my hope is that those changes that come over from Medicare into the commercial space allow the plans to be much more efficient in how they spend the money. And produce better outcomes.
Yeah, and I think you're saying like there was a venture capital firm that you were aware of that maybe invested in a hospital system or something to that effect that was looking to try to test this idea of accountable care and at risk, so the hospital system has the same incentives or outcomes that the patients have. So, like, I don't know if you can say much about that on the podcast or not, but that's an interesting pilot, if you will.
Yeah, I think it was late last year, late 2023. It might have been Andreessen Horowitz or General Catalyst, but they bought a health system, and I think the intent is to use it almost as like a test ground. So not just for how to efficiently run these accountable care organizations, but also how do you leverage like really modern technology throughout the entire delivery of care process, and that includes this type of preventative outreach stuff to try to control that stuff before people actually end up in the ER. It will take a few years to play out.
Sure.
But I'm optimistic in the sense that at least somebody is trying it and capital is flowing in that direction.
Yeah, and I hope so. And I'm always a little bit inherently skeptical of capital flowing into the delivery side of healthcare, because that means the presumption is obviously they think there's an opportunity to make more money. And I think some of the reasons we're in this predicament are because so much money has been injected to the delivery side, especially in the hospital side, to maximize revenue. And there's all sorts of gamesmanship that happens there. But I do believe if operated the right way, operationally efficient, maybe reduce some of the administrative burden that often comes with running a hospital system, and some poor incentives around billing practices. There's a lot of cleanup that could be had. But I think in theory, you could reduce the overall revenue of a hospital system, but inflate the margins or increase the margins by running it in an efficient manner and running it in a ethical may not be the right word, but a more ethical manner than some of them are run today. I think the good in me, maybe the idealist in me, thinks that those things can be true. It's the same as maybe wanting to add muscle and lose fat simultaneously. I think, yeah, that is theoretically possible, but I'm going to be a little bit skeptical until I actually see it happen.
Yes, I would agree with that. I think if I think out a couple of years, I think that might be the only way those hospitals stay financially sustainable.
Okay.
Because the way it is now, they're just bleeding revenue to all of these outpatient, like surgery centers and stuff like that. The most profitable services are kind of going elsewhere.
Okay.
So they are bleeding money. I think for them to stay financially sustainable, they're going to have to figure out how to make these ACOs work. And a big part of that certainly going to be the technology component.
Well, that's cool. Well, that's definitely giving me food for thought, so I'll pay attention to that category. I want you to do this, Justen. Closing thoughts, man. I know we covered a lot of ground, and honestly, like, this is a really fun podcast for me. And I mean, it's a little bit element of nerdiness, but there's some, cultural component to this. Obviously the self-funded component. It's been fun for me. So let me just say thank you first and foremost. But folks that have listened this far, what's something you might want to leave them with to think about?
I would say, I think, not just in terms of the type of AI Verikai does, but AI in healthcare in general, I'm so optimistic about it just because we are such early stages in this. Like, if you remember 10 or 15 years ago, a lot of hospitals still didn't have EHR systems, right? Only in the last couple of years have they become technically interoperable, although in name only, right? They don't talk to each other. The early price transparency files were totally useless.
Yep.
But it's all getting better. And the more that the systems talk to each other, the more tools like ChatGPT can make them talk to each other, even if the manufacturers don't want you to. And the more data becomes available, and it's becoming a self-fulfilling cycle, right? More data, better models, kicking off more data. So I think I think 5 or 10 years out, I know people have been wrong in this prediction before, but I think it's possible that healthcare will truly be different.
I think it's inevitable, right? And I think it's one of those things I'm grateful to be alive when I am, hopefully to see some of that evolution happen. There's been a lot of people that have come before us, and there will be a lot come after. They're still working on the problem. Everybody seems to think like during their lifetime healthcare is going to collapse, right? Or we're going to have something in the wake of it. I don't know if that's going to happen, but I do think the model that will exist in the not too distant future will be almost indistinguishable from the current model we have today. I agree with you. AI is going to have a role to play in that. I think it's also the people are going to have to play a role in that. The average American or average human being needs to be more aware of some of these issues that we're all solving. And hopefully we can attract really young and smart people to be interested in this industry to come help us solve it. But my hope is that whatever the system is that comes out the other side, whether it's parallel or in the ashes of the existing system, that'll be far better and far fairer for everybody involved. That's my 2 cents.
I agree.
Awesome. And podcast in. All right, guys. Well, thanks, Justen. Again, I appreciate you. And hopefully in a couple of years, we'll have you back and we can hear about your foray into care management. Thanks, man.
Thanks for having me.